If you swallow a blood pressure tablet every single morning, Amlodipine, Losartan, or Lisinopril, let me ask you something honest. Do you actually know what that tablet is doing inside your body at this very moment? Not the paragraph on the package insert, not the quick line your pharmacist typed on the label. I mean, truly know it. How the mechanism works, how it can shift from helping you to quietly harming you under the wrong conditions, and which warning signs separate something you can manage at home from something that needs immediate attention. I ask this question regularly to people I meet, thoughtful people, organized people, people who handle their own finances and stay informed about the world around them, and most of them pause. That pause is the whole problem, because these are not mild substances, these are not nutritional supplements. Amlodipine, Losartan, and Lisinopril are serious pharmaceutical agents that alter the way your heart, your blood vessels, and your kidneys operate every single day. And yet a remarkable number of people take them each morning the way they brush their teeth, out of habit, without any real picture of what to monitor, what to avoid, or when a feeling that seems perfectly ordinary is actually your body trying to flag something important. I'm Dr. Adam, and this channel exists to fill exactly that gap, to give you the kind of honest, practical, medically grounded information that a 10-minute appointment rarely has room for. By the time this video is over, you are going to understand these 3 medications at a level that makes you genuinely safer, meaningfully more confident, and far less likely to be blindsided. I want to start with a man named George because what happened to him captures everything we need to work through. Before I do, take a moment and tell me your name and where you're watching from in the comments below. I go through every single one, and I genuinely want to know who I'm talking to. George was 72 years old, retired school principal, meticulous about everything, including his medications. He had a system for his pills that would have impressed a hospital pharmacist. When his cardiologist introduced amlodipine into his daily routine, George treated it the way he treated everything else, methodically and without complaint. One more pill, one more box to tick, no reason to think twice. That attitude cost him nearly 4 months of his life. Within those months, George's ankles had swollen to the point where his leather shoes sat unused by the front door. His legs felt like sandbags by early evening. He started skipping his afternoon walks because movement seemed to make things worse. He quietly told his wife he thought something was going wrong with his circulation. He started researching heart failure online at midnight. The real explanation was far simpler and completely fixable, but George had never been told because nobody had ever sat down and explained to him that amlodipine, Losartan, and Lisinopril are not the same class of drug. They share one outcome: lower blood pressure. That is where the similarity ends. Amlodipine is a calcium channel blocker. It works by loosening the muscular walls of your arteries so that blood travels through them with less friction and resistance. Lisinopril is an ACE inhibitor. It blocks a specific enzyme responsible for tightening blood vessels, and by removing that tightening signal, pressure drops. Losartan is an ARB, an angiotensin receptor blocker. It interferes with the same blood pressure regulation pathway, but engages it at a different point, and that distinction matters far more than most people ever realize. 3 different mechanisms, 3 completely different side effect profiles, 3 completely different sets of things to watch for. Once you understand that, you stop reading every sensation in your body through the same blunt lens. George's swelling was not circulation failure. It was not his heart giving out. It was amlodipine doing precisely what amlodipine does in a meaningful proportion of the people who take it. It relaxes arteries more efficiently than it relaxes veins. Blood flows into the lower legs more freely than it flows back out. Fluid builds in the surrounding tissue. George was back in his walking shoes within 3 weeks once that was identified and addressed. The name printed on your prescription bottle is not just a word, it is a category, and the category predicts the pattern. Let's go deeper. That swelling deserves more attention because it is one of the most consistently misunderstood side effects across all of blood pressure medicine, and it catches people off guard more than almost anything else connected to amlodipine. Here is the simple version of what is happening inside your legs when amlodipine loosens the small arteries running through your lower limbs. Blood rushes in with less resistance than usual, but the veins that carry that blood back upward toward the heart do not respond the same way. They don't relax in parallel, so you end up with an imbalance. More blood arriving than departing. Pressure climbs in the small vessels around your feet and ankles. That pressure eventually forces fluid out through the vessel walls and into the soft tissue surrounding them. What you feel and see is puffy ankles, socks that press deep rings into your skin, shoes that no longer close properly, and legs that feel swollen and heavy by mid-afternoon. This is not the result of eating too much salt at dinner. This is not a sign that your kidneys are struggling. This is not the early stage of heart failure. In the vast majority of cases, it is a predictable physiological consequence of how this particular drug works. Now here is where the real danger enters. Not from the swelling itself, but from what people do when they see it. Some people decide on their own to simply stop taking the medication without informing anyone, and their blood pressure begins climbing silently back up while they feel as though they made a responsible, logical choice. Others keep taking it but drastically cut back on water because they believe they are retaining fluid. That reasoning points in entirely the wrong direction, and becoming dehydrated while on a calcium channel blocker introduces a separate set of problems. Others, like George, simply carry the discomfort quietly for months, gradually shrinking their daily activity, preparing themselves for the worst, losing quality of life that never needed to be lost. The response I want you to remember is this. Leg swelling while on amlodipine is something your prescribing doctor needs to hear about, not because the medication is necessarily wrong for your situation, but because there are adjustments, alternatives, and practical strategies that can make this far more manageable, elevating your legs during the day, adjusting when you take the dose, or in some circumstances reconsidering whether a different medication is a better fit for your body. All of those are legitimate paths forward. None of them open unless you say something. If you are currently taking amlodipine, leave a comment below. Have you ever felt that heavy, swollen, tight sensation in your legs toward the end of the day? You may be surprised how many people watching this video right now are quietly experiencing the exact same thing. Let's move now to Lisinopril, and specifically the most well-known side effect in the ACE inhibitor category, the cough. Not congestion, not mucus, a dry, persistent, maddening tickle deep in your throat that tends to flare at night and refuses to respond to lozenges, antihistamines, cough syrups, or anything else you've tried. What makes this particularly difficult to catch is the timing. It frequently does not arrive right away. Some people develop it within the first 2 weeks on the medication. Others go 3, 4, even 5 months before it appears. And by then, the connection to Lisinopril almost never occurs to them. The medication has been part of their routine without any obvious problems. So they blame seasonal allergies, lingering dryness from a cold, dust in the bedroom, acid reflux. I want you to hear about Margaret. Margaret was 68, a passionate home cook, and she was convinced her cough had something to do with spices or steam in her kitchen. The timing seemed to support that theory. It had started in the middle of a season where she was cooking heavily for family gatherings. She tried an air purifier. She switched her cooking oils. She brought it up with her family doctor, who ordered a chest X-ray that returned completely normal. 7 months passed. The cough was unrelenting. Her sleep was broken nearly every night. She was exhausted and quietly frightened that something serious was going undetected. When she came to see me, one of the first things I asked was whether she had started Lisinopril around the time the cough first appeared. She stopped mid-sentence, picked up her phone, and started working through the dates. She had been on Lisinopril for 10 months. The cough had shown up roughly 3.5 months in. She had never once made that connection. Once we identified Lisinopril as the likely cause and coordinated with her primary physician to transition her to Losartan, which works on the same general pathway but does not produce this type of cough, the tickle in her throat disappeared within 10 days. 7 months of shattered sleep resolved in under 2 weeks because someone finally asked the right question. Now, I need to draw a line here very clearly because there is a symptom in the ACE inhibitor category that is not an inconvenience. It is a medical emergency. If you are taking Lisinopril and you notice swelling developing in your lips, your tongue, your face, or your throat, especially if it becomes harder to swallow or your breathing feels restricted, you do not wait to see if it settles. You do not call the office the next morning. You do not take an antihistamine and monitor it overnight. You call emergency services without delay. This reaction is called angioedema. It is uncommon, but it is real, and it can compress your airway far more rapidly than you would anticipate. A persistent dry cough is a frustrating side effect. Swelling in the throat is a life-threatening emergency. The distance between those two things is critical. Please, keep it somewhere clear in your memory. And if nobody has ever laid out your blood pressure medication this plainly before, subscribe to this channel right now, because what comes next in this video could be just as important for your safety or the safety of someone close to you. Now let's turn to Losartan, and a risk I find particularly worth emphasizing because it does not arise from carelessness. It comes from people actively trying to do the right thing for their health. Losartan, like Lisinopril, works on the renin-angiotensin system, the body's central mechanism for regulating blood pressure. One of the effects of this class of medication is that it can cause potassium levels in the blood to rise. For most people on appropriate monitoring, this remains within a safe range. But layer in certain everyday lifestyle choices and the picture shifts significantly. Here is where it becomes counterintuitive. Potassium does not only come from bananas or from supplements you deliberately take, it is present in substantial quantities in products that are actively marketed to health-conscious people, specifically salt substitutes. Many popular low-sodium alternatives, the ones sold right beside regular table salt, often labeled as heart-friendly or physician-recommended, achieve their low-sodium profile by replacing sodium chloride with potassium chloride. So a senior who has been advised to reduce sodium purchases one of these substitutes, uses it generously across every meal throughout the day, and is now introducing significant amounts of potassium into a body that is already chemically inclined to retain more of it due to the medication. The combined effect can push potassium to a level that disturbs the electrical signaling system of the heart. And here is what makes this genuinely dangerous. Elevated potassium does not always arrive loudly. It sometimes introduces itself as unusual heaviness in the muscles, persistent tiredness that has no obvious explanation, cramping in the legs, a tingling sensation in the fingers or hands, or a fluttering irregular quality to the heartbeat. Sometimes there are almost no symptoms at all until the situation becomes serious. Think right now about someone in your life, possibly yourself, who has switched to a salt substitute at some point in the past year or two. If that person takes Losartan or Lisinopril, that is a conversation that needs to happen with a doctor, not because the medication is inherently dangerous, not because potassium-containing foods are something to fear, but because the combination, without proper awareness and monitoring, can produce a slowly building problem that was entirely preventable. Electrolyte powders, Certain meal replacement products and various over-the-counter recovery drinks also carry meaningful potassium concentrations. They are not prescription items. Nobody thinks to disclose them, and that is precisely why they warrant attention. There is one scenario that does not receive nearly enough discussion when blood pressure medications are the subject, and it affects older adults more directly than any other group. What happens to these drugs when your body is under stress from illness? Not a serious hospitalization, just an ordinary stomach virus, a few days of vomiting, diarrhea that persists, loss of appetite for 2 or 3 days, or simply a hot stretch of weather with heavy perspiration and insufficient fluid replacement. When dehydration sets in for any reason, the same dose of Losartan or Lisinopril that was carefully calibrated for a well-hydrated body can behave in dramatically different ways. Blood pressure can drop too low. The kidneys, already working under strain because of the fluid deficit, become considerably more vulnerable. Dizziness, pronounced weakness, near fainting, or acute kidney stress can develop faster than most people anticipate. The medication has not changed. The internal environment of your body has changed, and the drug is now operating in conditions it was never calibrated for. This is among the most practically useful things I can share with you today. Illness rewrites the rules. And if you do not have a plan for what to do when illness strikes, whether to hold a dose, at what point to contact your doctor, which symptoms should prompt an immediate visit, you are carrying a meaningful gap in your safety that does not need to be there. That plan should come from your prescribing physician before you ever find yourself needing it. If you do not have one, bring this question to your next appointment. Ask directly, what should I do with my blood pressure medication if I come down with a stomach illness or cannot keep fluids down for more than a day? It is one of the most important questions you can put to your doctor, and it is also one of the least frequently asked. Quick question for you right now. Has your doctor ever given you a specific plan for managing your blood pressure medication when you get sick? Drop a yes or a no in the comments. I suspect most of you already know how you are going to answer. Here is a situation I want you to picture clearly. You have a rough week. Your joints are flaring. Your knees ache going up the stairs. Your lower back is stiff from the moment you wake up. You go to the pharmacy and pick up ibuprofen, something you have used reliably for years, an ordinary over-the-counter purchase that anyone can make without a prescription. Now you are also taking Lisinopril or Losartan. Perhaps you are also on a diuretic for additional fluid management. This combination, used with any regularity, can meaningfully reduce blood flow reaching your kidneys. And in the presence of even mild dehydration, the risk of kidney injury rises in a way that is not theoretical. This is not a rare edge case. It is one of the most frequently occurring and most entirely preventable situations I encounter. The reason it keeps happening comes down to one thing. People do not categorize ibuprofen, naproxen, or similar anti-inflammatory medications as real medications in the same sense as their prescriptions. They are just something from the shelf, something for the pain. But your kidneys respond to chemistry, not to where a product was purchased. If you regularly use anti-inflammatory pain medications for joint pain, arthritis, or back discomfort, and you take any of these 3 blood pressure drugs, please have that specific conversation with your prescriber. There are frequently safer paths available: acetaminophen, topical pain relief options, physical therapy approaches, other alternatives that do not carry the same kidney burden. You do not have to simply absorb the discomfort, and you do not have to silently accept the risk. There is almost always a better option. You just need someone to help you identify it. I want to spend a moment on something that sounds minor and is not. Dizziness. That brief unsteady moment when you rise from a chair or step out of bed in the morning. The room shifts for a second, you reach for the wall, then it clears and you carry on, telling yourself you just moved too quickly. For many older adults on blood pressure medications, This is a routine occurrence, and it is almost universally underreported because it feels too trivial to bring up. Here is what I need you to genuinely absorb. In older adults, a few seconds of dizziness is sufficient to produce a fall. A fall is sufficient to produce a fracture, and a fracture, particularly of the hip, can redirect an older adult's health trajectory in ways that take years to recover from, and sometimes do not fully recover at all. This is not exaggeration. It is the straightforward intersection of physics and biology, and it deserves serious respect. The dizziness occurs because your blood pressure medication is performing its function, reducing blood pressure. When you stand up rapidly, your cardiovascular system has not yet had the moment it needs to compensate for the change in position. Pressure drops briefly. Blood flow to the brain decreases momentarily. You experience it as that tilting, light-headed sensation. The adjustment is often very simple. Rise deliberately. Sit on the edge of the bed for a few seconds before standing fully. Keep one hand on something stable when getting up. Give your cardiovascular system those extra few seconds to catch up with your body's new position. But beyond that physical adjustment, dizziness that occurs consistently, dizziness that does not improve after the first few weeks on a new medication, or any episode that brings you close to actually losing consciousness, those are signals that deserve a real clinical conversation. The dose may require adjustment, the combination of medications may need to be reviewed, something about your hydration pattern may need to change. Treating this as too small to mention is not a small risk. I want to address something that generates a great deal of unnecessary anxiety and sometimes triggers genuinely dangerous impulsive decisions among people managing blood pressure at home. Blood pressure is not a static number. It moves continuously every hour of every day in response to an enormous number of variables. How well you slept, whether you had caffeine this morning, whether you are in pain, whether the act of taking the reading itself is making you anxious, whether you just came in from outside, whether you raised your voice right before sitting down. One elevated reading on an ordinary Wednesday morning after a restless night does not mean your medication has stopped working. One low reading after you have been outside sweating in the heat does not mean your dose is too high. What carries meaning is the pattern that emerges over time, measured with genuine consistency. Same arm, same time of day, after 5 full minutes of quiet sitting, without rushing or conversation immediately beforehand. When people monitor inconsistently and react emotionally to individual readings, the decisions that follow are rarely sound ones. Extra doses taken out of fear. Doses skipped because one reading looked reassuring. Urgent calls to the doctor about a number that in proper context was entirely unremarkable. Monitor with discipline. Track the pattern over time. Bring that record to your appointment. Let the pattern, not the moment of alarm, lead the conversation. That one shift in approach lowers anxiety, improves clinical decisions, and gives your doctor far more actionable information than a single screenshot from a moment of worry. If you are finding real value in this, type the number 9 in the comments right now. It is a simple way to let me know you are here and that this is reaching you. These medications are designed to work through sustained, consistent presence in your system, not peaks and gaps, not reactive extra doses when a reading alarms you, not skipped doses on days when you feel well. Amlodipine, Losartan, and Lisinopril are not rescue medications. They are not built to be taken the way you take a pain reliever after a headache has already started. They are designed to maintain a stable chemical environment inside your cardiovascular system continuously over time. When that consistency is broken by missed doses, double doses, or irregular timing, your blood pressure can swing in ways that feel like the medication is failing, when the real problem is simply the pattern of use. If you miss a dose, the general principle for most blood pressure medications is to take it when you remember, unless the next scheduled dose is already close, in which case you skip the missed one and continue normally. You do not take 2 doses to compensate for one missed. But rather than rely on general principles, ask your prescriber directly for specific instructions for your specific medication and situation. Write that answer down, put it somewhere you will find it. Keep it with your medications, because in the moment when you realize you have forgotten, clear written instructions are worth far more than a guess. I want to close with what I believe is the most important point in this entire conversation, and it is one that rarely gets said plainly enough. The best blood pressure medication is not the one that produces the most impressive reading on a monitor. It is the one that you can take consistently, safely, and comfortably within the full reality of your health, your other medications, your lifestyle, and your daily routines. A medication that looks outstanding in a chart but costs you sleep every night, swells your legs until you stop going outside, or makes you so unsteady that you are afraid to stand up, is not a successful medication for you, regardless of what the numbers say. Side effects are not weakness, they are not oversensitivity, they are information, they are your body communicating through the only language available to it, which is symptoms. And those symptoms deserve to be heard, taken seriously, and addressed with genuine care. Too many older adults endure side effects in silence, under the assumption that needing the medication means tolerating whatever comes with it. That assumption is not medically accurate. Options almost always exist: dose adjustments, timing modifications, alternative medications from different classes, combination strategies, but those options only become available when you speak up. Silence is not the same as compliance, quietly enduring a side effect that makes you dread. The morning is not dedication to your health. It is a setup for the day you stop taking the medication entirely without telling anyone. And that is when blood pressure rises back up, and everyone around you is caught completely off guard. Your voice is a clinical instrument. Use it. Here is the simple framework I want you to carry with you from this video. If you take amlodipine, watch for swelling in your legs and ankles, particularly by late afternoon, and report it rather than endure it. If you take Lisinopril, watch for a persistent dry cough that nothing resolves, and understand clearly that swelling of the throat or tongue is an emergency that requires immediate care, not observation. If you take Losartan, watch for signs that potassium may be climbing, things like unusual muscle heaviness or an irregular heartbeat. Review carefully what is in any salt substitute you are using and have a sick day plan established before you ever need it. With all three, stand up slowly and deliberately to reduce full risk. Monitor your blood pressure with a consistent, methodical approach. Never combine casually with over-the-counter anti-inflammatory medications without guidance from your doctor, and never stop any of these medications abruptly without speaking to your prescriber first. You chose to watch this video all the way through. That tells me something about the kind of person you are and how seriously you take your health. I hope what you found here was not fear, but clarity. Because clarity is what transforms a prescription in your hand into a treatment plan you genuinely understand and can manage confidently. If this gave you something real, share it with someone you love who is navigating blood pressure treatment, because this is the kind of information that quietly protects real people from real harm every single day. And subscribe to this channel, because Dr. Adam will keep bringing you exactly this honest, practical, medically grounded health information that actually makes a difference in your life